hospital. This just to note that this is my perspective that I did. Although in my country there are some government hospital which is actually they have some let's say infrastructure that they can do, but unfortunately I couldn't get this chance, and that I'm working now in a periphery in a hospital in which there is no orthopedic theater even. I'm just working as an outpatient. So I choose the private hospital to build up my setting, and from the instruments I ask the hospital to buy it. Otherwise I buy it from myself, and I also bought it when I attended many courses from the booths, and get some tubular system, percutaneous screws, and other. The equipment, unfortunately, we can't buy it because I'm not rich enough to buy microscope or O-arm or any other. So I choose some hospital that's available that they have actually the microscope. Another point, the implant that we need, which is actually available also in the hospital, and we can work on it. Starting from the human resources, I think that you have to work in a center that you have every other specialty, so you can consult them any time when you need. And also you have to have a surgeon, a surgical team that you help to achieve your surgery, in addition to the radiology team. And I think what I'm doing, that I call my radiology specialist for every case that I think that it required some let's say details about his clinical condition and the other. And also don't forget the vascular or the general surgeon or the neurosurgeon that you need, because we face some emergency cases that we call our vascular surgeon, he attend in time. So another point, hello, are you hearing me?
Yes, go on.
Yeah, another point, the system. In my country, we don't have actually special guidelines to follow it. So I depend personally on the global guidelines, including AO Spine, North American Spine Society, which they have a very good guidelines for many pathology treatments. So please follow it. From the support or data registry that we need, again, I have my personal one that I collect, which is a simple Excel or software in my PC. But also I contact with the global data registry system of Eurospine, and I have an account and I submit my cases there as a data registry. Community awareness and education, I'm always put in my social media, or recently I developed my own website that's medical blogs and awareness for the patients about medical facts and other in both Arabic and English. And also I took a time for my with my patient, that's giving some advice for them, because we don't have, let's say, a solid let's say resources about that. Courses and workshop, I think that's AO Spine. They have a best and a very good foundation for achievement, and we as an Iraqi chapter, we got lots from them, and that impact our career. Regular assessment, what I'm doing, that's I'm already a reviewer in many journals. So whenever I review a paper, and at the same time I'm doing a self-assessment of myself, and also I attending the online webinars and the other. CME is not indicated in my country, but for myself, I did a requirement for myself that I have to do or to reach, let's say, special point every year. And research center, I built up a research team. We published last 3 years about 8 papers, and we go on with any paper in the process. Financial support, we don't have, especially we have small companies, they support the employees with assurance, And the government, if you, as I told you in the beginning, I'm not working in a good private government hospital to do these cases. Charity hospital, I didn't face it in my practice actually in Iraq, but most of the patient, they pay from their pockets, so they can't offer these expenses in their practice. These are my career. I started in 2010 by attending one first course in AOS spine in Amman, and in 14 I did my first TLIF cases, and I attended an AOS spine fellowship in Germany. In 16 I attended a fellowship in Seattle, and I purchased the set of tubular and started my tubular discectomy. In 18 I went to Korea to see what's going on in endoscopic spine surgery, and started my percutaneous pedicular screws and MIS TLIF. And in 19, I began my career as a AOS spine chairperson of Iraq chapter. And in 20, I just purchased the endoscopic spine, and also I started to arrange many online courses with my colleagues in Iraq. So I think that perfection is the enemy of the progression. So if you wait for perfection, I don't think that you can proceed or you can do any things. These are some cases. This is a first 46 years old male with back pain and radiculopathy associated with paresthesia. This is his X-ray and this is his MRI. And we did a tubular discectomy, and we face a vascular injury. We call the vascular surgeon, and this is the result of the CT angio, which is a pseudoaneurysm at the site of the 5S1, and he did a repair. And the funny thing that this is a case with Dr. Haider Qatran, and one of the limited resources that we are suffering from, that's the social problem. And Dr. Haider by himself, he pay about $20,000 because as a social compensation for the cases because of this complication. We published this case in a medical case report, SEG Open. And the second case, 50 years old, backache with right radiculopathy, failure of conservative treatment. And this is presented with 5S1 high-grade spondy. And I did what's called the transsacral fixation. Actually, I learned this surgery from one of the lecture from Seattle Science Foundation. And this is a cage that we put it from the sacrum to the 5S1. And this is the X-ray. And this is a CT 6 months later, which is seen as solid diffusion between 5S1. The third case, 63 years old, weakness of both lower limb 1 week, constitutional symptoms, and he presented with ACSC with the blood test, elevated ESR C-reactive protein. This is a case that's have a lesion at the level of the 12L1, and I did a posterior vertebral resection or resection. X-ray, last one was before 2 years, which shown solid diffusion, and the patient regained his full movement. This is the case. And the fourth case, that's a 60 years old male with lower limb weakness for 1 week, ACA-B below the T3, and loss of urine and fecal control, neck swelling, and ESR C-reactive protein is elevated. This is a case which show the lesion, which is mostly a tumor lesion, which was obvious as the primary from the thyroid, because this is the thyroid. So we couldn't go from anterior. I approached it from posterior. I removed the body and put the fixation. And this was the X-ray post-op. Actually, the patient developed a chronic infection one year later, and I removed the implant and just the cage, and he is in good condition. The fifth case was 55 years old female, back pain, more than 3 month constitutional symptoms, left-sided weakness grade 1, and he has a history of the DVT. This is a case which is similar to the case before. I did a 1-level TLIF with posterior fixation for her. Last case, 65 years old female, neck pain for 1 month duration, paraplegia below the level of the C6. no history of a chronic disease. This is his X-ray. We thought that this is actually an infection, but the biopsy was secondary metastasis from prostate. And this is the X-ray, and this is the team that work. Actually, I did the surgery with my friend Loay from the hospital. All these cases that we did, that we don't have O-arm, we don't have neuromonitoring, we don't have actually from the start even the microscope, but we proceed in our cases. So my take-home message that you can use your limited resources to achieve your goal, and try to work as a team, be friend with your team, listen to your mentor, as I did here with my mentor, Dr. Mzahem, and choose the right setting and build up a good connection with the other specialties. Start from yourself to build your own system. Don't wait for the others, and invest in medical business also. This could be a bias, but I already did. So my final slide, that stay strong, believe in yourself, and never give up. Thank you.
Thank you so much, Ghazwan, for this very nice, informative presentation. So we learned from you that limited resources is not only equipment and facilities, it's also awareness and mentality of your community, because this is one of the limited resources, especially in cultures in our country and some of the nearby countries. So we have to take all the opportunity to deal with all the complications possible, not only complications that can happen from the unavailability of some of the equipment, but also complications that can be happen from other causes other than the equipment. So you shared with us very nice cases, starting with very, very limited resources at earlier of your career, and now you reach the I can say unlimited resources in regarding the facilities. But still we have lack of a lot of things, including awareness of the community and availability of the personnel. Thank you a lot, Ghazwan. Now I would like to ask our mentor, Professor Roger Halter, the pioneer in MIS, who participate in camping in many countries with limited resources, to share his expertise in this field. Please, Roger, share your screen.
Zaim, you're too kind. Thank you so much for the introduction. And are you in Erbil now?
Yes.
It's my favorite city.
You're welcome to come at any time.
Oh, I would love to come back. I was in Sulaymaniyah, I was in Erbil, I was in Najaf.
Yes.
And I had always an amazing time with your countrymen and your friends and everybody else I met. So I really miss traveling and meeting you guys.
Thank you so much.
Now, thank you for having me. I'm actually in the operating room. I'm preparing a case, so I have the vascular surgeon work on that case right now. And it's actually a nice example, and I'll talk about that case in a few minutes. So I want to talk about, how to preserve resources, and that, as Allah knows, who came to Tanzania last year to operate, I do some work in low middle income countries with limited resources. And we had, during the COVID crisis here in New York, we had the opportunity to actually really think about these things, being directly affected by limited resources. So for those reasons, this topic is actually not only relevant for people who live in other parts of the world other than North America, but it's actually very relevant, it was very relevant for us here. And what I want to focus on is a little bit a different angle. As you know, I really like MIS because I believe that there are a lot of advantages, but the reason that I like it is really the fact that I believe that it can avoid bigger surgery, and you can actually save resources, and more importantly, you can do a smaller operation in a patient and you can avoid the much bigger operation, which typically would be a fusion operation. You can frequently avoid that if you are technically skilled and equipped to do certain types of decompression procedures that preserve the stability. And I think that's a great example on how surgical technique will allow you to save resources. If if you only have to fuse 10% out of 100 patients rather than 100%, you save a lot of resources. If you do a decompression, rather than thinking that you have to do a fusion and you do it for the right reason, you save a fusion operation in 90% of certain types of patients, and that saves a lot of resources, not only in Iraq or elsewhere, but also in North America and in Europe, and that's a huge benefit. And how can you achieve that? That's patient selection, and that's adherence to certain surgical basic techniques that I'll talk about. So since this is an AO course, I thought I should bring this up here. We just published in Global Spine a special edition on minimally invasive surgery, and we also published our work on the curriculum. We've put together with the AO a curriculum for MIS procedures, and I want to mention that here since it's an AO course, and hopefully you have access to that at some point, or maybe even now. I'm a big proponent of acronyms and trying to make things easier to remember. And the 6 T's are really summarize kind of the main points that it takes to become a successful minimally invasive spine surgeon, or any spine surgeon really. And the one that's the most important is really target. That's patient selection. The least invasive operation is the one that you don't do because the patient doesn't need it, okay? And then at the same time, so many times we see patients who undergo crazy surgery, fusion surgeries, right and left, for pathologies that could really be treated with a decompression if you know how to safely do that. So tools, technology are important. I'm not going to talk a lot about that, navigation, cages, and so forth. Surgical techniques, I'll really focus on surgical techniques. Teaching and training is important, of course. That's what the curriculum is for. Testing is research. I think all of us, we need to document our results. We need to keep track of our results and then somehow have that influence our future decision-making and surgical performance. And then obviously talent. We're not going to talk about that. But what I really want to focus on is the ability to perform a bilateral decompression using minimally invasive surgery through a unilateral approach. Why is that important? Because you minimize iatrogenic instability and you will be able to decompress pathologies where many other surgeons believe that you have to do a fusion. Now, the ability or the surgical technique is not new. This was described in the 1990s in Europe, in North America. This is one of my favorite books on spine surgery by John McCullough and Paul Young. He's still practicing in St. Louis, Paul Young, and he's actually very involved in global surgery. He spent time in Tanzania and so forth. So he wrote this book, An Essentials of Spinal Microsurgery. And you can see from this drawing, this describes with open surgery, the idea of performing a unilateral approach and then achieve a bilateral decompression by looking under the spinous process. And you can do that very effectively with tubular surgery, for example, but also with the endoscope, of course. In North America, it was Kevin Foley, who's really one of the pioneers of MIS, who started using tubular retractors for microdiscectomies. And then it was Sylvain Palmer, who's a neurosurgeon out on the West Coast, who started using tubular retractors for lumbar spinal stenosis. And when I trained with Volker Sonntag in Phoenix, who didn't do any MIS surgery, but he allowed me in the early 2000s to use tubular retractors for his patients when I was a fellow, and that's how I really got involved with tubular surgery. And when I came back to New York, I started using tubular surgery for all of my cases. Now, this is a good example. This is a patient with grade 1 spondylolisthesis and very severe lumbar stenosis. And the question is, does this patient need a fusion? Now, the guidelines that are still circulating, the guidelines, orthopedic neurosurgical guidelines for the performance of fusion surgery will tell you that you have to do a fusion. You can't just do a decompression in this patient because that patient will fail. Well, I will tell you, and many others will tell you, and I think the literature shows that in selected patients with this type of pathology, you can do a decompression and you can save resources by not having to do a fusion. And how can you do that? With minimally invasive surgery, either with the endoscope or with a tubular retractor or with a specular retractor. as long as you do a unilateral approach for bilateral decompression. In my practice, this is the biggest saver of resources. The fact that you can avoid fusion surgery in these types of cases that are so common, degenerative spinal disease in old people. Instead of doing a fusion in everybody, you do a fusion in those who really need it, which is maybe 10, 15%. You save tremendous amounts of resources. So, and you achieve that by doing a tubular decompression. You undercut the spinous process rather than removing all those elements that potentially contribute to spinal stability in these cases. Now, how do I select the patients where I can get away with a decompression? Obviously, I examine the patient. The history is very important. If they have what I would call mechanical back pain with heavy motion, I'm more inclined to offer a fusion. I get flexion extension films. In this case, this patient has minimal motion at L4, L5. So if the flexion extension films don't show any motion, I'm inclined to do a decompression rather than a fusion. And I look at the MRI scan. If the MRI scan shows that the patient has foraminal stenosis, like in this case here at L5S1, and if the patient is truly symptomatic from this, meaning this patient has L5 radicular shooting pain down the leg when he's standing and walking, then I need to be able to decompress that nerve with my operation. And in this particular case, for example, a decompression with a tube would not work because you can't get there, you can't really decompress the nerve. So this patient, for example, would need a fusion because that's the only way that I can decompress that L5 nerve. And then I look at the shape of the lumbar spinal stenosis. If the patient is symptomatic from severe lateral recess stenosis, like in this case here at L4-5, L5S1, I can decompress that just by removing the medial aspect of the facet joint. But if this pattern is present at L1-2, L2-3, L3-4, it'll be very difficult to do that without injuring the pars and causing instability. So in that case, I may be more inclined to do a fusion. So you got to look at the clinical presentation. What's the patient really symptomatic from? The x-rays, does he have mechanical back pain or not? And the MRI scans, of course. So let's go back to that case that I showed before, the lumbar spinal stenosis with spondylolisthesis. One of my fellows, Carsten Scholler, he did a study, a meta-analysis a few years ago that we published, looking at all the studies that look at patients with spondylolisthesis who undergo either a laminectomy, open laminectomy, or a minimally invasive decompression. And if you look at those studies, you will see that you can perform a very successful decompression with minimally invasive surgery and really achieve a very, very low rate of delayed fusion surgeries later on, meaning that those patients come back with instability. If you do an open laminectomy, it's about 13%, I think, at an average of 2 years or so, versus 3% with a minimally invasive laminotomy. So it is true that if the only thing you know how to do is an open laminectomy, you're probably better off fusing these patients. But if you know how to do a minimally invasive laminectomy through a tube, then you can do a decompression. And patients who have minimally invasive surgery are generally happier because there's less pain, they go back home earlier, and so forth. So you can select the patients, you can do a decompression without having to do a fusion in these patients. Now, in this particular case, we did a tubular decompression. That's the postoperative MRI scan, just to show you how nice the decompression is. And I want to walk you through the procedure because I think that it is important for surgeons to at least know a little bit about how to do a tubular decompression. Tubes are, some surgeons use syringes. They cut the edges off the syringes. Even in North America, some surgeons like doing that. So these are pretty straightforward tools. This walks you through the surgical steps of performing an L4, L5 over-the-top decompression in a patient with severe lumbar stenosis. From the right side, you dock through tubular retractor, that's the X-ray. You find the inferior edge of the L4 lamina here, and then you start drilling that away until you reach the insertion of the ligamentum flavum cranially. Then you remove that. And then the key is to get over the top contralateral. The key is to rotate the table away, tilt the tube so you can get this angle under the spinous process. See, I do this under the microscope. You can do it through the loops as well. The microscope is nice because you have obviously better visualization. And we call it the over-the-top decompression. There's even a movie, a Hollywood movie. If you haven't watched it, during COVID was a good time to catch up on movies. So it's one of my favorite movies, of course. And then once you're done with your decompression, you have a beautiful decompression of the thecal sac, the contralateral nerve root, the ipsilateral traversing nerve root, and so forth. And that's just under the microscope, looking at the contralateral lateral recess, how we separate the dura from the ligamentum flavum. And then we drill. That's the key. That's the part that most surgeons have problems with. How do you drill through a tubular retractor over the top, over the dura, and protect the dura at the same time? You do that by keeping the ligamentum flavum intact, and you drill behind the ligamentum flavum. And then once that has been released, you can remove it with a Carrison rongeur and get a beautiful contralateral decompression. And you can see here now, you can see both sides of the dura, they're nicely decompressed. So that's the key of getting a bilateral decompression. You can do that in the cervical spine. This is an MRI scan of a patient with severe cervical stenosis. Now, this is obviously a case you could easily justify doing a multi-level decompression and fusion. But this is where patient selection comes in. This is an 85-year-old gentleman who had a myelopathy, and the myelopathy really came from the C4, C5 level. He didn't have any neck pain. So we did an over-the-top decompression under the microscope just of that one level. And in this case, we used navigation to kind of confirm the anatomy. If you have navigation available, it comes in very handy, obviously, for these operations as well. And we published that with the video and so forth. So how do you save resources with MIS surgery? Well, because you can avoid fusion surgery in certain patients. You can treat in patients who come in with two-level disease where one level is clearly unstable. I will frequently do a one-level XLIF or TLIF and then just do a decompression through a tube at the adjacent level instead of doing a two-level fusion. That also saves resources. And then most synovial cysts I would treat without a fusion with a tubular retractor in these patients. So MIS is not only minimal invasive, but also minimal and measured instrumentation surgery, in my opinion, in my practice. We wrote all this up, all the little tips and tricks, how to perform the tubular decompression. And then you can do multi-levels. Michael Meyer described that very nicely in this article, where you can treat multi-level lumbar spinal stenosis with the so-called slalom technique, where you make multiple incisions and go in with the tubes and then individually decompress each level. These are like little tips and tricks how to do this. I'm not going to go into this because I think we're running out of time. I just want to mention again, this is an AO course. We spent 2 years with a group of 8 surgeons from all over the world, putting together all the little tips and tricks for how to incorporate MIS surgical techniques into your practice, how to use a microscope, how to use the endoscope, how to use the drill, how to minimize fluoroscopy time, how to use navigation. And then finally, we put together procedures, the tubular over-the-top decompression, the MIS TLIF, percutaneous pedicle screws. That's all available via AO on their website. I think you have to sign up to some of those courses. They have videos available. And now we're expanding this also to talk about OLIF and XLIF approaches or lateral approaches in ALIF to expand the spectrum of the curriculum. And these are just some examples from our educational material, or the AO's educational material, talking, for example, about a over-the-top decompression here, also how to fix a CSF leak through tubes, MIS TLIF procedure here. It's also on your iPhone, you can download it, and that's it. So that's what I wanted to talk about, target and the 6 Ds, and how can you use this to minimize the invasiveness of your surgical procedures, and most importantly, have great results in your patients and save resources. Thank you.
Thank you so much. Thank you for your presentation and for your expertise in this field. Many thanks for your time. We have quite some questions for you, but I will just shift now to Ahmed. Ahmed, please to share the result of his cases he presented earlier, and then we will go to the questions and answer. Ahmed.
Yes, I come back again
Yes.
to the polls of the questions. I'm sharing now the second poll. It's the same questions and same cases. So in case one, after these 3 presentations of the well-known surgeons, what do you think now? This case one is enough surgery, is good surgery if you are doing this in developing countries? In 24 years old, L1 fracture, fixed posteriorly only 2 level above, 2 level below. Is it enough surgery, need anterior instrumentation, or is it over instrumented already, or can be done much more better in another way? So please, you can vote now. For the second case, you will see this is a 50 years old lady presented with back pain and radiculopathy, and she has been operated a few months ago. You can see now this is a unilateral fixation passing from L3 to L5 only, and not including the L4. And it's, in CT scan, you can see there is an out of pedicle screw. So for this patient with back pain and radiculopathy now after this surgery a few months ago, is it enough surgery? You can do only interbody fusion and correct the problem, or it is already bad surgery, need revision, or you can do much more better surgery for this patient. You can see there is no limited resources here, because
Ahmed, can I say something? Sorry, it's Dr. Hartle. Sorry. I'm sorry I missed the case presentation, but this is a case where I clearly would like to know what were the patient's symptoms, and this is not a case that could have been done with a decompression. Based on the x-rays, and I apologize, I didn't see the MRI scan. I'm just saying, just looking at this, looks to me like total over-treatment. But maybe not. I'm just saying, I mean, I would want to know if this patient really had radiculopathy, is there something that we could have done with a decompression and we would have avoided this disaster now?
Yeah.
Very good point, sir. Yes, because I mean, in this case, it's not only the limitation of resources, but maybe the bad choice of kind of surgery with overuse of the resources.
Yes, that's, we are talking not only about the limitation in screws, because limitation of the education, decision, learning of the surgeons, or something else like those mentioned by Ghazwan already. So for case 3, you can see this is 60 years old lady with lumbar stenosis and instability. She was treated by fixation from L3 to S1. So do you think this is enough surgery for this patient, or you just only add interbody fusion to be a perfect surgery, or you see this over instrumented surgery, maybe long bars, or no need for this connecting bar, or you can do much more better surgery for this patient? You can see there is a higher D12L1 stenosis already, and it is not included in the surgery. So you can now vote. You can see the poll high up in the question and answer, and the poll of the question. Please vote, and we can see.
Ahmed, do we have time for what only?
Yes, you can. Okay, I finished now. So the take-home message from this presentation is that surgeries can still be done well in limited resources settings. One, we should differentiate between malpractice and the limited resources surgeries. spine surgeons in a place where there is limited resources still able to perform great jobs and excellent achievements like that done by Dr. Ala and Dr. Ghazwan, as he presented already. Surgical skills and decision making are much more important than sophisticated equipments and plans. You can do surgeries, good decompression surgeries without tubes or without endoscopes, and it will work. Thank you very much.
Thank you so much, Ahmed. I think this is the best take-home message that we can reach with this webinar, that resources is not, limitation of resources, not only facilities and equipment, it's also knowledge of the personnel and the teamwork and many other things. I would like to ask my faculty some questions from I got from the chat. So the questions to Roger. Roger, please. Can you tell us in your practice how many cases you treated with only decompression that presented to you with minimal instability, and then you decide later on to revise it with a fusion? I mean, the percentage of cases in which it comes to you with minimal instability, and you decide to do it with decompression alone, and then you have to shift to fusion. Just to have an idea about this, because I mean, this is one of the hot topic nowadays, that many surgeons argue about fusion or non-fusion in minimal instability cases.
Yeah, and I think that is a very important question. You know, I really go through a lot of steps to convince myself that somebody doesn't need a fusion. You know, I look at the type of the back pain, the mechanical back pain, yes or no. I look at the facet joints. I look at the flexion extension x-rays. I look at the degree of spondylolisthesis. And then I also talk to the patient. You know, there are a lot of patients, they're happy to take a risk that they may have to come back if there's a reasonable chance that they won't come back. In my practice, I would say maybe 10–15% of patients, you know, come back, maybe need a fusion later on. And that can be because they develop instability at that level, or maybe they developed a problem at an adjacent level, and then we take care of both and maybe do a fusion. But it is a very low number, and I can tell you that I think that I think it's much worse to fuse everyone and then have to deal with the complications from the fusion than to try to avoid a fusion and then maybe have a few people come back and do a fusion later on. You know, this is not, what we do is not like brain aneurysm surgery where people, you know, die if you don't do, you know, an adequate job the first time. You know, it's all about pain. And I think that that second case that we saw before, in my opinion, is a disaster, because now you're dealing with somebody who would have had a decompression and now has a 2-level fusion, and it's going to evolve into this cascade of more fusion surgery, you know. So that's my, that's my thinking.
Yes, thank you so much, Roger. Another question. In cases where you want to go an overtop decompression, how far you can reach with this overtop? I mean, in which case you need to do bilateral decompression at the same level and not to decide to do overtop? For example, foraminal stenosis or what? What's your opinion?
Well, you can go all the way. I did a case last week, was a physician who came in with severe lumbar stenosis, and then he had a extraforaminal disc herniation on the other side. And I wasn't sure, you know, I wasn't sure if I was going to be, I was going to do 2 operations, but then I decided I was just going to try to decompress the lumbar stenosis from one side and then go over the top all the way into the foramen. And so I was able to undercut the foramen on the other side and reach the far lateral disc herniation on the other side. And that is an extreme case, you know, yes. and I used navigation for that case because it was really nice to see. But for the most part, you get a much better decompression on the contralateral side than you get on the ipsilateral side. And as a matter of fact, that's the main limitation of this operation, because if you got to take that into consideration when you choose from which side you go in. because you get a better decompression contralateral than ipsilateral, you know,
Okay.
but you get overall, you get a very, very adequate bilateral decompression.
Perfect, perfect. Thank you so much. So a question to Ala. Ala, I got this question from the participant. How can you achieve fusion in MIS? You have showed us a case when you treated the scoliosis with an MIS. Did you perform a fusion, and how can you get this fusion with the MIS?
Yes. Well, actually, we must have, as you said, as all of the presenters talked about type of thinking. This is very important. So when you do the fusion, you skip 1 or 2 vertebrae maximally. You don't skip a lot of vertebrae to do minimal. So you can see, if you see the x-rays of the patient and the incisions, it's just skipping 1 or 2 vertebrae. And in every vertebra that you do fastectomy, you do appropriate fusion, and you put appropriate screw size. This is one important factor that some people would be a little bit worried and put, for example, 4.5 screws instead of 5.5 screws, or 5.5 instead of 6.5. So the rigidity of fixation is important. The type of rod is important. It shouldn't be, by all means, less than 5.5 rod. And you can have access to one of the facet joints if you even skip 2 vertebrae. So it will be nearly a full fusion, but the fusion is very important. You don't skip fusion for technical issues. The main pathology that you need to correct is to correct and fuse. Yes.
Yes. Ammar also asked about the did you fuse the apex, or only you put an apical screw in the cases?
Well, I don't know what he means. First of all, if we talk about the adolescent idiopathic scoliosis case, it's mainly correcting the apex. You fully correct the apex, putting screws in the apex fully, and you correct it, and you correct the anchors above and below. But if he means about the early onset scoliosis case, that we control the apex, this is the APC technique that I'm doing. You mainly control the apex. Actually, it is not a fusion technique, and it is in the early onset scoliosis. It's a little bit type of thinking, it's non-fusion technique. So the APC, you do tethering technique on the convex side. So you remodel the most wedged vertebra, and with growth, it will correct spontaneously. This is the main issue. So you need to be fusionless. Because of that, now I'm shifting to do percutaneous screws on the apex of the curve in the APC, so as to decrease the incidence of fusion. It's a non-fusion technique, because in the early onset scoliosis, the main problem of the Sheila procedure, because McCarthy fused the apex of the curve, so he had 62% with his publishing paper in 2017 of crankshaft phenomena, because you stop the height, but you don't stop the growth anteriorly. My APC technique, it is correction through modulation and growth, posteriorly and anteriorly. Because of that, we had lower incidence of crankshaft phenomena.
Thank you so much, Ala. I have a question from Ayad. It's to all the faculty. He's asking about when you have cases where the MRI did not match the physical examination. He means the right or left. Actually, I have cases like this in which I saw the patient, examined the patient. He's complaining from the left-sided radicular pain, and then when I examined the MRI, I found that it's more on the right rather than on the left. His question is whether to follow the clinical examination or follow the MRI in choosing your approach for surgery. Personally, I will follow my clinical assessment rather than the MRI. What's your opinion, Ala?
Well, generally speaking, when we talk about medicine, the investigations will augment, will improve, increase the perfection of your opinion. It's not a substitute. So you need to be appropriately examining the patient and putting it in the priority. And the MRI should be going with or without according. So the main issue is appropriate clinical examination. I mean, in surgery, in medicine, whatever.
Yes, Roger, you have good facilities in your center. I mean, to diagnose, for the diagnosis and everything. What's your opinion about these cases? Did you ever face a case in which the clinical examination different from the MRI?
Yeah, we have those cases all the time, and we have a conference every Wednesday where we meet with pain management, physiatry. We have a muscle specialist there. We have a psychologist there, and we discuss those cases. And very frequently, we will end up doing injections, nerve blocks, you know, because a lot of these patients, they may have SI joint pain, piriformis pain, facet pain that's not so evident on the films and is not necessarily a surgical target. So they may present with a you know, very confusing clinical picture, and that's where that's where communication and those subspecialists become really important. We the other thing that comes out, a lot of degenerative problems with the spine, a lot of it is muscle. You know, a lot of patients have muscle as the primary cause of the pain, or post-operative. You know, they may have a beautiful operation and then they still have a muscular source for pain that needs to be treated with strengthening, physical therapy, and maybe injections. So it can be really complicated, but I totally agree with Allah that that the clinical evaluation is much more important than the MRI.
Yes. Yes.
Can I comment?
Do agree with you? Yes, Allah.
That especially in limited resources countries, sometimes people would skip some tethering, something like that in the MRI. So trust your clinical examination more. And as Roger said, you need to talk to other subspecialists to re-evaluate the patient again. Especially in our countries, we have these problems.
Yeah.
Yes.
In all countries.
Yes. Last questions from Wael. Do you have any clue about the neuromuscular scoliosis, CP neuromuscular scoliosis, how we achieve correction with minimal cost and less surgeries, especially for families in our country? Do you want to spend money on CP cases?
Well, this is another thing. I do a lot of neuromuscular. Every pediatric spine surgeon is faced with these cases of CP and other neuromuscular problems. And you do it in the same manner. The problem of the neuromuscular scoliosis, when the family comes to me, I tell them that the most important problem is the preoperative preparation and the appropriate intensive care unit. Take care when you begin doing neuromuscular issues, you might lose the patient because of something not related to surgery. For example, you have in these patients with neuromuscular disorders, you can the deformity is so flexible that you can just correct it so easily. But the problem is, like in myopathies and these kind of things, the excessive bleeding, the respiratory system, the pulmonary function, the post-operative minute, you might lose the patient because of that. So take care about these things and have always a team with you doing these things, and also always do protein and albumin because of the nutrition, because there is a high incidence of infection in these patients. Take care about that always. Don't rush to the technique by itself, especially in neuromuscular. Take a team, and especially the pediatrician, the intensivist, and the blood supply for the patients.
Thank you so much, Ala. Ahmed has a comment about the Ayad question about the MRI. He said that it could be a root anomaly when you have clinical signs out of the MRI. This is one of the comments came by Ahmed. Muhammad Khattab also sent us a comment from Egypt. Thank you, Muhammad, for your participation with us. He believes that it's important to stick to the basics, anatomy and biomechanics, and adhere to common things and common sense in dealing with such kinds of pathology. Thanks a lot. As we come to the end of this webinar, I would like to express our deep thanks and appreciation to Roger, Ala, Ghazwan, Ahmed, to all our faculty and participants for dedicating your time to participate in this webinar. And I just want to remind you that we have another webinar about spinopelvic relations next Friday, inshallah. So hope to see you next in another IO Spine events. Thanks a lot and keep safe.
All the best. Bye-bye.
Thank you
Thanks.
very much.
Thank you so much.
Thank you.
Thank you, Anna.